You know, when treating open bites, a change that was paramount was the tandem that we did with my father, Pepe, who is my mentor and my inspiration, my father, Pepe. And he always, when I have a problem with the tongue, I say, hey, please, tell him your points to the patient and tell him how to approach the tongue positioning to do not interfere in our objective of closing the bite. So he, for some reason, he's so effective in this, so we wanted him also to explain his point of doing this case. Ves pujant perquè we are going to start. Come. Because I will be explaining the case. In the meanwhile, Pepe is preparing for telling you exactly what he is going to, how he explains to the patients, the positioning. Espera't, ves posant-te perquè jo ara t'ho dic quan.
All right.
This is Pepe Carriere. Wait, 1 second, because we start a little bit with the patient. So patients like those, patients that they have an open bite, if we do not train the tongue, if we do not position the tongue properly, if we do not release the problem, the one that generated this problem, that is the tongue of the patient, we are never going to accomplish any result on those cases. So first thing to do is to remove the noxa causalis, the reason of the open bite. And the reason of the open bite is the incorrect swallowing in the incorrect position of those cases. So this is how my father explains the treatment. So in those cases, in the upper and the lower, in the open bite and the deep bite, we are going to approach the first stage, the sagittal correction, exactly with the same way. Exactly. Means that we place the motion appliance from 3 to 6, we place a vacuum aligner in the lower, we place a molar tube. If we can use the second molar, we use the second molar. If not, we use the first molar. But we accomplish the class 1 occlusal platform in both cases on the same way, with different results. In the upper, in the patient of open bite, we will start closing the posterior segments because it will be a certain eruption of the upper canines, that an intrusion of the lowers that will intrude the posterior segment and cant the occlusal plane, and this will help us into closing the posterior areas, the canines, premolars, and molars. Why we are able to close that? Because Pepe has done his homework in putting his message inside of the brain of the patient and saying, patient, if you don't put your tongue in the proper position, you will never accomplish what we need to accomplish. So here is what Pepe is going to show us now. Now, position. Yeah. Okay.
Well, first of all, I have to say hello to everybody. Very happy to be here with you, such a select audience. And this setup, you know, is like an advanced, like in the astronautic world, technology, with high-end imaging. Henry Schein has arranged a beautiful thing here.
Absolutely.
Outstanding, visionary. Thank you. Well, open bite. Open bite, you see, for a young orthodontist, is a pain in the neck. It was, at least. And the pain in the neck was because, you know, the request of every single mother to an orthodontist says, doctor, how are you going to finish that case? In how much time? Is it going to finish well? Because these teeth do not work, you know. He's an ugly girl. Oh, he's not, I don't see her happy. I see her tongue always in front of my nose. No, you got to wrench that. I felt so unsafe, you know. And we had experiences with therapists, with orthophonists, money and months and months, and finally said, okay, this is a personal affair. So I concentrate on children, and I devised a very simple system the most simple possible, and it is in agreement with the basics of our philosophy of treatment, even with the sagittal first, because all the attention we promote in the mouth of the patient is the attention in the back part of the mouth, the one that they do not use at all. They're acting always in the front teeth with a big tongue like a big New York sirloin steak. When they open the mouth, you see it there, boom, laying down, you know, between the teeth, like a hot dog. So, here we are. How I was thinking, how shall I explain that? Well, I explain that, I will explain it exactly as we do explain to the patient. In a didactic way to a child, they follow it well, and we take a good result on that. Everything, if you accomplish, if you give the message and the message gets through, your treatment will be short and clean. If not, you better don't step in. So we never start a treatment without spending 2 to 3 months of therapy, or at least watching how the patient is doing and how it's evolving. It's in a long range, the evolution. But in 3 months, we have enough to see a flare of change. You see, if the tongue is repositioned, you will see that everything settles a little bit, then you are safe, you can step into the case. Now, what do we train the patient to? We train three stages. While rest, with the tongue at rest, with the tongue in action while chewing, and with the tongue in action while swallowing. 3 steps to learn. For instance, let's see a patient. In front of a patient, I never tell the patient to feel guilty about what he's doing with the tongue. But when you say, it's because of you, you put the tongue in between your teeth, the patient, he starts like that, then you're done. Nothing goes through. You have to approach the patient and say, look, you do things with your tongue that you ignore, and you don't want to do it. But I will give you an information because you're a clever girl, and you will understand that. So pay attention to that, because you don't know you do it, you know. You are ignorant. You are not guilty for that. Okay, then the arms get open, then you are through. Here
Body
we have an
language.
open
Body
bite.
language.
Yes? Yes, sir?
Body language.
Body language. Oh, yes, that's true. Thank you. Hey, here we have an open bite. I give a patient a class of anatomy also, you know. Class of anatomy, see, here are your eyes, your blue eyes, beautiful eyes, you see. Here's your upper jaw. Here are the molars. We are talking about class 2. I will draw a class 2 case. And see, I tell, look, here your enemy is the tongue. In a class 3, the tongue lies like that, like a big steak between the teeth. In the class 2s, the tongue acts like that, like a big steak on top. But in both cases, we train the same thing, class 2 and class 3. So we tell them, look, my friend, I will teach you how you have to behave while you are at rest. What is your name? Tom. I personalize. Everybody likes his name written and listen to his name. They love it. This is a personal thing for them. At rest, you have to do 3 things. 1, you have to keep your lips parted, separate lips. Why? Because you have to let the atmospheric pressure to go in and out of your mouth a little bit. Not just the mouth open, just the lips a little open, you know? Not in contact. Why? Because if the lips are sealed, the tongue has the temptation to go as a third point of contact and goes automatically forward. So if the lips are apart, the tongue, it's easier going back. Then, okay, so you, as a second point, you put the tip of your tongue at A. A point is this, at the end of the palatal rugae. Say, like if you were horseback riding, you know, on a pony. If you were horseback riding, all the time you have to act as if you were horseback riding. So put the tongue back. And then, at the back of your tongue, at the base of your tongue, you try to swallow it and descend it into your mouth. The patient is in front of me, and I show him, and I teach him, and he does it to me. I accept it, or say, no, repeat, until he gets it, and then he receives his congratulations. So this is the first step, right? While at rest. So base of the tongue, back and down. Easy, huh? All right. Then we go. Now I will show you what do you have to do while you chew. I write it here, chewing. Tom is already written in the first one, right? And here is Tom. It's open bite. See? And I'll show you exactly in an open bite. I have to tell you something. An open bite, the tongue is big because the patient with an open bite doesn't contact the teeth. The only teeth that contact are the molars. So his implication in the chewing with the teeth, he doesn't use them. You know what he's using for chewing? The patients of this type, for chewing, they use their tongue. They impact the food with the tongue against the teeth. From a banana to a steak, they eat it a little bit with the back teeth, but they swallow with the pieces of wood. They swallow food, not masticated, you know. But you know what happens? The muscle of the tongue is an striated muscle. A striated muscle, when you exercise it, it becomes strong. They have a Rambo tongue. A Rambo tongue. I tell them, you have to, if you put a cast on your leg when you have a broken bone, your musculature in 2 weeks becomes thin. I would like you to keep your tongue quiet, so the bird inside of this cage will be smaller. It will not have such a volume conflict. So I tell them, look, what do you have to do? Is it two? I went. That's it. It changed. You see, in this particular case, a patient doesn't know well, but I tell him exactly what do you have to do. First of all, the lips, again, have to be parted. To be when they are parted, the pressure gets inside, even the tongue doesn't get prisoner of that thing, and the tongue, it's easier to go back. So, with the lips parted, and the second provision is exercises with chewing gum. between the molars. And the tongue has to accompany the bolus of chewing gum between the molars and chew them only in this area. When they chew this exercise and they know it very well and they get rid, with the lip sparter, they get rid of this area. You extrapolate this to regular food. This is simple. Patients, they understand it easily, very easily, you know. So these are the three things that they have to do. Lips parted, chew gum to get power on the masticating masseters and temporalis musculature, and they extrapolate this to the regular food. And there's a third provision. We do training for swallowing saliva, water, and food. In this particular case, also I propose to keep the lips parted, even with water sometimes, because if they not, water is the only exception if the patient cannot, but always lips parted it's very helpful, you know. Then, to swallow, I have to do three things synchronically. Synchronically means at the same time. Chew gum, walk, and scratch your head 3 times at the same time. 3 things at the same time. Lips parted, clench with the molars. In the molars, you have to clench. And then you have to swallow from the A point back. In other words, you say, first, lips parted, clench with molars, and swallow from here back. And I teach them a rhythm to do that at the same time. So, lips parted, clench and swallow. Lips parted, clench and swallow, all at the same time. Like if you were trying to chew the back section, or the posterior, the inside cheeks, the part of your cheeks. Like you clench, swallow, and go from here back. This is the whole thing we do with these patients. And if we go through with this message, the patient will start a happy treatment, and believe me, you will get a beautiful result with whatever technique you treat your case. If you treat the patient with the soft wires, and if you treat the patient with non-friction wires, you do a benefit in plus to them, as we propose here. But with anything you do, and you will get rid of these sloppy cases, always with open bite, fighting years and years and years and years, and root resorptions, because I request you to check all the cases presented here with open bites. Check at the panoramic X-ray with the tips of the roots. You will see how are they. They are kept untouched. They are respected, you know. Well, that's all, my friend. Well, I appreciate your attention. This was the only thing. It's quite a contrast.
I have to tell you that we work together, and I ask advice on every patient, like always I have done. So, and amazingly, we have been working together 23 years. And every day I learned something new from Pepe, so is a cage of science for me. Eh?
I'm an old cat.
Yeah, an old cat. So how we treat this? Look, what we do is what we accomplish the posterior segment position. Pepe has already shown to the patient how to position the tongue. So from now on, everything is going to be easier. No competing forces from a tongue that is reducing our efficiency. But in the other patient, in this patient, we generated an advancement of the mandible, a reposition of the mandible that has uprighted the incisors and reduced and eliminated the deep bite of the case. So amazingly, in both cases, we are going to accomplish that. This is the case. Open bite at 29 years old. We place we have this scenario. We place the motion appliance. In 2 months and a half, we accomplish a class 1 platform. Those patients that they have this type of musculature, these open bites, the speed of movement of the posterior segments is ultra fast. It's much more difficult to move teeth in the brachycephalic patients, in the patients that they have musculature that is strong, that is consistent, that has a super solid occlusion. Those patients are more reluctant to the movement, okay? So what we do, we generate an overcorrection, 2 months and a half, and we overcorrected the position. Now we place the brackets. Pepe has already told those patients how to position the tongue, and the closing is easy, is automatic. On those patients, we always use also tongue tamers behind the lower incisors. Those are very helpful to remember, to refresh the mind of the patient, to position the tongue properly in the adequate position. But the most important thing, when you do not compete with the tongue, when you do not compete with forces that are against the intention of our movement, there is not back and forth, there is no way of going back and forth, and what happens is that it makes it so easy to close and end up a case that was complex in 11 months. 11 months closing the bite. The patient that had an open bite, 29 years old, with this technology, with this approach that is so minimalistic but also so efficient, of Pepe's technology to position the tongue of the patient, also accomplishing the sagittal condition at the beginning easily, we end up the case easy and with an ultra minimally invasive approach. Ultra minimally invasive approach that is also very respectful with the roots of the patient, because we have not been back and forth. And if we don't go back and forth, the roots of the patient are going to be ultra protected with not any single damage on this respect. How can we know if a patient is putting the tongue and properly during the process of treatment? Easily, if you touch the upper incisors or lower incisors and they are painful, the patient is positioning the tongue in the wrong position because there is a back and forth. If the teeth are asymptomatic, no problem on this respect. So here is the patient that had open bite, that now is a good-looking patient that now goes to have fun on the welcome receptions of the congresses like those and take care with the girls, always smiling and having fun and eating things that he can eat now with incisors that before never was possible. Eh? Now look at him, how happy he is, and this and that. So this is the objective, balancing the face, balancing the life of the patient, and in the best way, in the most simple and the most minimally invasive as we can, okay? So we have created a beautiful video now that was ended to be rendered tonight at 4 a.m. And here is Juan Carlos Bareche, who is the one. Juan Carlos, come here, please. Come. You know, I want to introduce you Juan Carlos because Juan Carlos is the one, those videos that we are seeing, that we are sharing, and you have on your folders. Juan Carlos, who is a good friend of me, he is a lion with a sheep aspect, eh? Because it's amazing. When he goes into a computer, we are on the process of creating a beautiful movie. In fact, when I came up with the idea of the motion appliance, first person I went to visit was Juan Carlos. And I came with a piece of soap, a sculpture with the idea that was in the mind. I said, Juan Carlos, put this in the computer, please. So we sculptured the motion, and we started from that time. And so today we have the motion because one day we were together working there in the computer. So I wanted to pay on to Yeah. Thank you, Juan Carlos.
Thank you,
Tonight he was until 4 a.m. working on this. So here is the movie that we have generated on regarding to the position on how to approach the system of treating these malocclusions for of the tongue positioning, like Pepe says. Okay, the incorrect position of the tongue while tongue sucking while resting or paying attention to things, or the incorrect tongue positioning while eating. The position of the tongue that goes forward and is positioned improperly. This generates open bite. This generates open bite. Or the incorrect position when the patient swallows, suck the lip and positions the tongue forward. This stimulates the growth of the tongue, and the tongue gets hyper big. The tongue is macroglossic. So now we have to reposition this and have to say to the patient, first thing, part your lips. Let the air from outside come into your mouth. Position the tongue in the palate, the tip of the tongue on the palate, and put the posterior element of the tongue down. Now, the patient knows. Now, for chewing, do the same. On the B point, on the molars, clench, 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 and at this point, position the tongue on the upper palate. Now, how to swallow? Well, to swallow, you have to put your tongue back on the point A on the palate and push the food back with the tongue. So this is the way to do it. Once they understand how to do it, we can correct what? We can correct the open bite that was generated by the wrong positioning of the tongue. How we correct that? Well, we place the vacuum aligner. Now we place the motion. We choose the color motion. Color motion, which is something that is lovely, and I love it. So we accomplish the class 1 platform. Now what we do is we place the second stage of treatment. Now with the sagittal condition is corrected. We extruded, we intruded, and we canted the occlusal plane. We placed the tongue tamers to help the patient remember that the tongue has to go back. Now we align. We close the spaces with the power chain, those spaces that reopen in the front side, and now we change for the 1425, we align, then we change for the 1725, we align a little bit more, and we change to the 1925, and we retract the anteriors, finishing the case without the competence, without the interference of the tongue. Now we are able to treat this beautiful seabird, because it looks like a seabird, but that is the way that we like to approach. So this is the case of the open bite. But what about the deep bite? The deep bite was treated completely the same. The patient has a complete deep bite, but the treatment was completely the same. Retroinclination of the incisors, full step class 2, block the mandible back. It's completely different. So the question is, shall we treat those cases differently? Is the motion appliance efficient in those cases? Shall we go in this? Can I go? Of course. We are treating the sagittal condition. We are changing completely the element, the way to approach the case, and simplifying what we want to simplify, that is the overall process. How? Changing the sagittal scenario into a new scenario for a simple finishing. So what we do, we place the motion, we choose the second lower molar. Always when we have the second lower molar, we choose the second molar. And then we place the motion from 6 to 3. We start and we accomplish easily a class 1 occlusal platform. Normally, those cases are more difficult to move than the open bite cases, because the occlusion, because the musculature makes more rough to correct. Probably, in a case like this, we can need maybe 4 or 5 months to accomplish the class 1 platform. But nothing happens. We elongate a little bit, and sometimes we need double rubber bands at night to boost a little bit the process. Could happen. Nothing happens. Then we can switch into the brackets. Then we can go into the process, align, torque, intrusion, and whatever. In this particular case, looks like a little bit disoccluded because we bonded bite ramps behind the upper incisors to even work more on the intrusion. So in this case, this occlusion of the posterior segments is not real, because what we have is disoccluded with bite ramps in the anterior lingual sides of the uppers. Now we end up the case, now we finish the case, And the patient is not anymore with deep bite, it's with a class 1. And the interesting thing as well is that the mandible of the patient has gone in a better scenario. And not only the mandible, just the airway of the patient is wider. A narrow airway that was at the beginning, that was increased the airway after the motion, now has a beautiful airway at the end of treatment. And this is very important for the prevention of the sleep apnea problems. Open bites, girls like this that are coming with open bite with a former treatment of orthodontics, typical treatment of impaction of the posterior elements. How many times we find cases of 4 extractions that they simply ruin the profile of the patient? This is what we have to avoid. Patient is not a set of teeth. It's a human being with a face that this face has to be used to attract to the love of her life, right? So we cannot scramble and we cannot play games on that. So it's interesting because patients that, well, end up a treatment of 4 extractions like this, and they want a treatment of Invisalign, we can simplify so much. So what we do is we place the motion, we open the spaces, we generate a correct positioning. As we do not extract material, as we do not remove material, we are not going to change anything in the outside of the face. So now we switch into Invisalign. But Invisalign what? Very short Invisalign, 15 aligners. 15 aligners of Invisalign. 15 aligners of Invisalign is something, you know, you can ask for an Invisalign Lighty that is 14 aligners, much cheaper, you know. 14, 15 is the same. I'm not super expert. We have one of the popes of Invisalign, that is Dr. Garino, that is one of the real experts of Invisalign. I'm not an expert on Invisalign. I'm a regular user of aligners. I'm a regular user of aligners as a, but we are like this. So we place aligners and we end up easily into a good finishing. That is 3 months of motion, 15 months of aligners, 6 months, 6 alignment refinements, 6 more aligners of refinement, which is, we could have asked perfectly for an Invisalign Lighty in a case like this, case that should be very complex to solve, but because of the motion has become an easy case to solve. So here we have the patient that has a completely different scenario without the profile problems that we had at the beginning, without the without the open bite. Open bite that was corrected because of the help of the technique of Pepe Carriere that was helping me so much. We are a tandem. So we treat all those cases that you see are not my cases, are cases treated by both of us. So it's a matter of the credits are for both, okay? Cases like this, in class 3. In class 3, what happens? We have this scenario, a patient of open bite and a patient of deep bite. Shall we treat them differently? Well, already we have seen that the sagittal condition does not affect to the vertical condition of the patient. So our main objective is going to be to convert this case into a class 1. Objective with the motion, even if it is in class 1, class 2, or even if it is in class 3, is to convert the case into class 1 at the beginning of the treatment. So what we do is, well, in a case like this, 21 years old, open bite, nice open bite, the other one 35 years old, deep bite with a complete impaction of the maxilla, that everybody was wanting to make surgery because it's a surgical case, but she's asking for an alternative solution to that. So orthodontics is a super powerful rocket. And if we manage this in a simple way and we are organized into removing all the complexities at the beginning, we can end up with beautiful results just using orthodontics. So this is what we do. What we do is we approach those cases on the same way. First thing, train the patient to the position of the tongue. Look at the tongue of the patient in the upper. She's perfectly aware that this tongue has to go into point A, right? She's perfectly aware of that. So now what we do is we start with the class 3 motion appliance in both cases, and we accomplish class 1. What happens? Well, in the case of the open bite, what we can see is that in the posterior segments, we already are closing the open bite. And in the case of the deep bite, we are seeing that we are already placing the relation in between the mandible and the maxilla, well, the mandible back. The mandible back in a better relation. Why? Because we also take advantage of the temporomandibular space, which is very helpful in those cases that the joint is in a different condition than in the class 2. In a different condition than in class 2. So let's focus on the open bite. On the open bite, what we have is that what we want to is to convert this case into a correct scenario. So here is the patient, placing the tongue back. So initially, what we do is that we place the class 3 motion. This is the scenario. The patient, if we want to correct on the class 3 cases, better extract third molars. Third molars are really bothering us in class 3s. We can accomplish beautiful results without extracting, but better remove the third molars if possible, if the nerve is not in the middle, okay? So we place the motion, we place an upper vacuum aligner in this case, because we don't want to have a protrusion of the upper lip, because this particular open bite case has an upper lip that is projected forward a little bit, and we don't want to bring this forward. So what we do is that what we are going to is bring back without altering this upper lip. If we have an upper lip that is acceptable, we use a vacuum aligner. If we have a premaxilla that is back, like in the deep bite, we use brackets from the beginning, okay? This is the difference. If we place brackets from the beginning, we will procline, we will fill up, we will bring forward the upper lip. If we place vacuum aligner, we will keep everything in place and beautifully. So we start like this, and we generate a little bit. Okay. Now, extrusion of lower canines, it's a must. It's something that is going to happen always in our class 3 cases, but it's a necessary step for the correction. So welcome it and seeing it without being fear of that. It's going to be something helpful for in our case. Will be an extrusion and an intrusion of the molars. It's a combination of both. And this combination of change, of counterclockwise change of the occlusal plane, is going to change the relation in between the structures. Now, it's easy. Now we place the tongue tamers. Those small spikes behind the lower incisors that help to the patient that already knows where to put the tongue, help the patient to remember always the tongue back, okay? So we end up, we finish, we generate a good deep bite, and now we end up with a solid and consistent overbite and overjet. Now the case is protected. Now the case is aware of the importance of this. And here we can see the protection of the roots. After finishing, all the roots are clean. Clean because there were no competing forces of the tongue. No competing forces of the tongue because we train the patient. If we want to succeed in open bites, always taking very much seriously that the major problem of the success in open bite is the tongue. If the patient positions the tongue properly, we will succeed. If the patients position the tongue wrongly, we are not going to succeed and we are going to fail. We are going to fail. 14 total treatment time. 14 total treatment time is a short period of time. Why can we accomplish something that seems so complex into a short treatment of time? Because we do not compete against negative elements in the middle. Negative elements in the middle. That's it. Sorry, there are some repeated. Now, the other one, well, we converted this deep bite into a correct positioning. In this particular case, the maxilla is impacted. So we are not going to place a vacuum aligner in the upper. No, we are going to place brackets because those brackets are going to bring forward, are going to generate, are going to bring those uppers forward in a better sagittal condition. Now, correct. Now, easy. Place brackets, finish the case. Easy point. From that point, it's so easy. From that point, it's so easy. easy finishing. So we end up, and she will need implants, she will need several elements. But the interesting thing is that from this point to the other, we gave an alternative of orthodontics without surgery. Alternative that is not only dental, is also facial. It's also facial because we invite to the mandible to be repositioned in relation to the maxilla. So a girl like this now is finished with a better maxilla. Better maxilla that now is much better than it was. So this upper maxilla was missing, now is better. We counterclockwise the occlusal plane, and we invite it to the mandible to be repositioned in the space in a beautiful way. Now, we can inject, we can give this small touch that we have to be experts in of contouring a little bit the upper lip in cases like this with a little bit of hyaluronic acid. This point will make the difference because now the patient will look nicer with a minimally invasive approach. And here we have a patient that in 14 months went from a retrusive way into a nice profile, into a better profile. Look at the change that could be perfectly of type of a surgical case. It's interesting to brainstorm about the importance of the facial icon. Another element that is very useful on those cases is on those papillas when patients, they have those papillas that has those triangles. If we can place a little bit of hyaluronic acid, push the papilla forward and finish beautifully with the papilla nicely, just with a little bit of hyaluronic acid. So helpful. Hyaluronic acid is very helpful in elements in our face. And for finishing, mixed dentition. Mixed dentition with class 3 is very important. Today we have the face mask. Face mask is an element that helps, but you know, it's a little bit of middle-aged design. We have to be clear. It's middle-aged design. So now we can end up with the minimally invasive approach, giving also a beautiful, effective effect on those cases. These two cases are completely different. One of them is class 3, the other one is a cleft lip and palate, you know? And the class 3 is a typical class 3 in which we could place a face mask. How can we change this? How can we approach in a case like this? Well, very easily, what we can do is we can put the motion appliance. And in the other case is a cleft lip and palate. Cleft lip and palate is not a class 3, but is a premaxillary hypoplasia, and the mandible grows wild because the maxilla is inefficient. Well, it's not a class 3, but the mandible grows in a wrong way. So we want to also bring forward the upper maxilla. The maxilla and balance the profiles. Let's see on patient 1. Patient 1, in mixed dentition, in patients that they have 7 years old, something like this, we have upper permanent molars, and we have the lowers, or even younger, we can use the temporary teeth. In this particular case, we use the upper 6s. So we place a rapid palatal expander that we normally expand twice a week, Wednesdays and Sundays, okay? And we start with the motion. Amazingly, after one appointment, the change of the relation of the mandible and the maxilla is beautiful. The change is very nice. So after 6 months of class 3 motion, 5 months or 6 months, I don't know, here we have the case. It's a complete different kit. But no, here is the face. Here, was here. The evolution of the case. So we change the evolution of this case immediately on this regard. And for finishing, because we are running out of time, what we are going to do is to see the cleft lip. Because it's interesting to see, you know. A cleft lip is a scenario in which the patient is born with the typical cleft palate and cleft lip. How we have to approach that? Well, here we are lucky in Barcelona to have Dr. Tresserra, who is probably one of the best surgeons on this regard in the world. No? And he is a case done together with him. Okay? So this is a typical case in which first thing to do is to seal the lip. Then, after, to seal the palate, to seal the mucosa. Then is when we appear and we bring the elements that happen to be disrupted by this congenital problem. And which is the problem that we are going to find? A premaxillary hypoplasia and a reposition of the mandible forward. So what we do is, first thing, is surgery of the lip. The surgery of the lip that Dr. Serra did is beautiful. He is an expert on this, and he does beautiful, beautiful plastias for those lips. Now, once the lips are closed, we have to wait. We have to wait for what? Well, first thing, 6 months of age. At 6 months of age is closing of the lip. At 1 year of age, closing of the hard palate. But hard palate is not the bone. It's just the mucosa. Just approximation and sealing the cleft palate just with the mucosa. But the cleft on the bone is there. So the underdevelopment of the maxilla is going to happen. Third is when mira bien sin pasas la vale. Is the orthopedic approach. 7 years of age is when we arrive and we bring the relation in between the maxilla and the mandible. Before, we were using face masks. We were using all types of appliances. But you know, a patient that is suffering so much since he has been born, to put a face mask is like torturing him. You know, I remember when I was a kid, they placed me for straightening my legs for sleeping. 2 months. Something that I still remember in the middle of the night. Imagine a face mask in the middle of the night. So with this, we end up to the definitive treatment with braces. And once we finish, what will happen is that the patient will have to go for the bone graft of the cleft, and secondly, for the finishing of the small defects on lips and wings of nose. So imagine how many steps a case like this happens to have. So what we do in a patient like this? Well, try to project, try to bring the upper maxilla in a correct relation with the mandible. So we place the class 3 motion, typical impacted maxilla, and in this particular case, we place class 3 motion with the palatal expander, and this will help into this change, into this invitation. Let's see. Here is the case, an impacted maxilla. We start with the class 3 motion. We start with the expander, and we, after 1 month, we will see that the case starts to be edge to edge. This is so effective. In mixed dentition, class 3 motion is amazingly effective. Always in your class 3, take pictures of the profile in every appointment, because the patient is very surprised on the changes once they see the comparison on the picture. This is the first month. Just changing. The position of the upper lip is already getting highlighted and in relation with the mandible. And now we keep going. Second appointment, a little bit more. We, in mixed dentition, we want to exaggerate. So we will bring our class 3 cases or our cleft lip cases into class 2, because the instability of the crowns will promote losing a little bit. So we want to overcorrect, always overcorrect. Keep going. Third appointment. Keep going. And now is the patient finished. Now, what we see? That the patient has a complete different scenario. If we look at the face of the patient, now has an upper lip that is balanced, now has a nice relation between nose, upper lip, lower lip, and chin. Now the patient is balanced. If we compare from the beginning to the end, in a short period of time, we upside down this disrupted profile into a balanced profile. So, according to the 10 months later, here it is, 10 months later, the patient looks nice, everything is in a good position, and the picture of the patient is balanced, the patient is growing, and is good looking. So I think we have covered beautifully what we wanted to start to cover today, and now it's time for the break, I think, right? My father has this page. See. Yeah, this is a page what he uses to explain to the patient how to place this. So if you want this page, maybe Celine can photocopy this, and for the ones that they want to use it, it's useful. The patient is very understandable, are the steps, and you can use it for your tongues, for your patients with tongue. Please.
Thank you. Thank you.